Happy holidays. Want to give your host a gift? Consider subscribing, rating, and reviewing the show this holiday season. It really helps the show grow. From all of us at Believe, have a Merry Christmas, everyone, and a happy holiday.
There's a one and done obesity medication that's on the table today that we're going to talk about, a drug that I'm going to guess 99.9% of you have never heard of. It's not a procedure. It's not Fractyl Health, which also saw a huge bump this week. It's nothing you probably heard talked about on TV, maybe this morning, or even heard about talked about in Reddit threads. And the company behind it just saw their stock explode over 150% today in one single day. That's because the data that landed on this, data tracking one injection, just one injection, looking at 3 months of data, these patients have less visceral fat, more lean muscle mass, and a cleaner safety profile than anything that we've talked about so far in obesity medicine. If that sounds unfamiliar, it's because this is like uncharted territory from what we normally talk about. So this podcast is going to be heavily weighted, no pun intended, on the future of obesity medicine. We're going to talk about a whole host of new medications in the pipeline for those of you who are slower responders or just interested in the field in general. And we're going to get into all of that together here on the Pen, the Weekly Dose podcast. Let's get into it.
Welcome to the On the Pen podcast with your host, Dave Knapp.
This is a wild week in obesity medicine. So the first story we're going to talk about today just dropped this morning. So this is brand new data as of this morning, but we're also going to get into some of the other data that we got this week on future medications and how this is all shaping up to really show us where this whole sector of obesity medicine is going. It's one of my most exciting topics to talk about, not only because I'm a slow responder to the current class of medications, but because there are so many other people with advanced metabolic disease, and we need continued innovation in this space. We need it. And so this is going to be a really interesting episode of On the Pen, the Weekly Dose podcast. If you don't know me, my name is Dave Knapp. I'm the man on the Mounjaro. That's why I'm here. You are on the Pen. Wegovy, Saxenda, Victoza, Trulicity, Mounjaro, Zepbound, Compound. That's what we talk about here at On the Pen. And so many of you within the community are slower responders to these medications or are looking at, hey, when are higher doses going to come out? When are we going to get the next generation of these drugs? What are the newer drugs that you're excited about? And what I've been answering that question with up until today is I'm more excited about the next thing just to come out, the next thing. Well, in reality, the next few things that are coming out are all oral versions that are weaker than the current injectable version. So they're not that exciting to me, although it does expand accessibility. It does increase the manufacturing capacity of these companies, allows them to reach more patients potentially. But at the end of the day, they won't offer a significant difference in the metabolic advantage. The metabolic advantage is really where this is headed. Like when we talk about retatrutide, we're talking about the current class of medications that really acts centrally. That's the basically the medical term, right? These current medications that we talk about, Ozempic, Wegovy, Saxenda, Victoza, Trulicity, these medications act by decreasing the amount of calories that you bring into your body. Now, they're helping you metabolically, to be certain. They're helping you be more insulin sensitive. They're helping to reduce inflammation. They're doing a lot of things outside of just reducing calories. But when we talk about strictly weight management, one of the primary methods that they're helping people control their weight is just simply by reducing the amount of calories that you take in. Now, retatrutide is still in this current class of medications, and they're called nutrient-stimulated hormones. GLP-1 and GIP are both incretin hormones, but we're going to talk about another hormone that is being targeted with a new generation of drugs called Amylin. That's Eloralintide, Cagrelintide. That is not an incretin hormone, but it's still a nutrient-stimulated hormone that works on similar pathways to reduce caloric intake. And then, of course, retatrutide has the glucagon component, which is going to be the first of the nutrient-stimulated hormone class of medications that actually helps you to increase your energy expenditure. But the one that we're going to talk about today, the new one that I was teasing at the beginning, comes from a company called Wave-007. And they came out with some interim data on a study called INLIGHT. So this data is fascinating. If you've been following obesity science for a while, this is genuinely one of the more intriguing molecules probably that you have heard about, because it's really one of the first that we're talking about that is not a nutrient-stimulated hormone receptor agonist type of medication. And it's a one-and-done injection. A one-and-done injection. So let's talk about Wave Life Sciences molecule, WVE-007. It's like the James Bond of weight loss, apparently. That's what we're going to call it here anyway. And by day 85 of your one injection, patients had an average of a 9.4% reduction in visceral fat. They had a 4.5% reduction in total body fat. And this is perhaps the most astounding statistic that we're going to talk about with Wave-007. That's a 3.2% increase in muscle mass. Did you hear me? That's a 3.2% increase in lean mass. And if you're looking at the placebo group, of course, as the standard, there wasn't any real meaningful shift. But looking at that increase in muscle mass, let's just talk about, let's camp out on what a big deal that is compared to the current class of medications. You know, I was ruminating this past week as we were going live, one of the other days that we were live. We're now going live every Monday, Wednesday, and Friday at 12 p.m. Eastern, giving you a daily dose of news in the obesity medicine space. That's in addition to what we're doing here on Tuesdays, which is our weekly rundown of the podcast. So some of it's stuff we talked about earlier this week, but we were talking about Eloralintide, which is Amylin, another nutrient-stimulated hormone co-secreted in the pancreas with insulin when your body consumes nutrients, right? So it's a nutrient-stimulated hormone, not an incretin like GLP-1 and GIP, but a hormone that works on a similar pathway stimulated by the intake of nutrients. So they belong to this niche category of medications. Now, Cagrelintide is a medication from Novo Nordisk that's going to hit the market probably in 2027, a topic that we talked about this week. We expected it in 2026, probably actually going to hit in 2027 based upon some market dynamics that have Novo delaying that one a little bit. But I digress from the main topic that I wanted to talk about, which is Eloralintide. And when we were looking at the data that we got, and we'll get into it a little bit later, we saw that 78% of trial participants in that group were 78% were women. And I got to thinking about this, and I got to thinking about some of the charts I've looked at in terms of how much weight loss with the current class of medications are from fat or visceral fat, and how much is from lean muscle tissue. Now, with Ozempic, semaglutide, we've actually seen up to 30% of the weight loss that patients experience can come from lean muscle mass, something that ideally you would preserve. You would preserve that with your weight loss. Now, with any weight loss, even without medication, you're going to lose a certain amount of lean muscle tissue. That's the reality. But there is something potentially about GLP-1, and you can see it because there's a difference across the different types of medications that you may be taking. Semaglutide and tirzepatide, for example, are not the same in terms of how much weight loss in the clinical trials came from lean mass versus fat. So where this whole sort of market is shifting towards is quality of weight loss, not just quantity of weight loss, but quality of weight loss. And with Eloralintide, looking at 78% of the trial participants as women, I couldn't help but think, why? Why? And I even said that out loud on the live stream. I said, why? I don't know why. And as I'm thinking about this, I'm wondering if it isn't because women in particular tend to have a lower amount percentage-wise of lean muscle tissue compared to men. And could that be the pharmaceutical company? I mean, it's all couched in, and we're doing it because this actually represents real world where more women use these drugs than men. Well, that's changing. That's changing every single day as more and more people become aware of the fact that obesity is a chronic, relapsing disease worthy of treatment. Men are getting treated too. So why are these trials not shifting? And I do have to wonder if it's because women achieve more fat loss and lose less of their muscle mass because there's less muscle mass to lose. I don't know. This is just a hypothesis of mine at this point, but but could it be that it's a clever way of sort of hiding some of those less savory data points that could come out of the GLP-1 class of medications long term? Now, I'm not saying this to hate on these class of medications. Again, weight loss in general comes with a certain amount of lean muscle mass loss, but I have been thinking a lot about this lately, frankly, because some of the biggest items in the news over the last few weeks are the fact that starting in April, tens of millions of senior citizen patients who are on Medicare will now qualify for GLP-1s to treat obesity. And I do think that the whole concept of quality of weight loss matters. It matters for everyone, but it matters even more for a vulnerable population like the Medicare population. And so anyways, when we look at Wave-007, sorry for the tangent, but when we look at Wave-007, we're looking at a potential of GLP-1 level weight loss, but from fat with an increase in muscle mass. So you're gaining weight in the muscle mass area, but you're losing the type of fat that you don't want, especially that 9.4% reduction in visceral fat, the fat around your organs, the fat that you ideally would want to get rid of when it comes to longevity. So Wave is totally different. It's going upstream of appetite, and it's going directly to the biology of fat and fat cells. The drug silences a gene called INHBE, which lowers a protein called activin E. Now, people with naturally lower activin E have healthier body composition, less visceral fat, and generally better metabolic profiles. So Wave is basically trying to mimic that protective phenotype in people who were not born with it. And early on, it looks like it actually may hold up and pan out. And the safety is very clean. No spike in nausea, no GI issues, no concerning changes in labs or liver signals, really no red flags. So this phase 1 in obesity looks cleaner than most of what we see in data from the nutrient-stimulated class of medications. Very fascinating. So that's the part that really made me pause here, because this could potentially be a once-a-year injection, maybe twice is what they land at, but you're not talking about a weekly shot, and you're not talking about a daily shot for sure. You're talking about something that fits into your life a little bit better potentially. I know that within this community, those who take this medication, we're sort of married to the routine and the rhythm of taking our weekly shot, and the idea of blowing that routine up, I think for some people it's like, no, I like knowing something's going into my body every week. It is the psychology behind this is all very interesting, but you do see that the pharmaceutical companies are moving that direction because it is marketable to people who have no idea, no routine to interrupt. Like, oh, I only have to take it once a month or once every 6 months or once a year. It tends to be more appealing to people who aren't in this like we are. And then, from the other angle, from the manufacturing side of things, it's less API to manufacture. It's less pens to manufacture. It's less cost and distribution to get these things to market, to get these things to the pharmacies. And so this is definitely the way that the industry is moving. And this is a very interesting molecule for sure. So they're already actually planning a phase 2 as a monotherapy and as an add-on to GLP-1. So even as maintenance after GLP-1, which could be a potential for people, which by the way, it's going to be one of the biggest categories in obesity medicine, whether we want to admit it or not. Like, people are terrified of the regain and they need something that helps to hold the line. That's why the Fractyl Health data that we got in their study on the Revita program this week, if you missed that update, basically people that come off of GLP-1s after losing 24% of their body weight, they got to their 24% weight loss with tirzepatide, they went off it, half received a sham procedure, half received this was an open label study, my bad. This is an open label study. The folks that got the Revita program actually ended up within 1.5% of their ending body weight at 6 months, and people who didn't get it actually gained 10% of their body weight back. So, we're talking about the future of obesity medicine in terms of maintenance now too, which is huge. They're doing a study in orforglipron. That's the oral small molecule from Lilly that's going to be coming at the beginning of next year. They're actually getting people to their goal weight with semaglutide or tirzepatide. In that head-to-head trial, they got the chance to go on orforglipron afterwards to maintain their weight. They're comparing that to placebo, and even if you got placebo and started to regain, there's actually something built in so people could get orforglipron as a rescue medication. So very interesting how this is all shaping up and how they're changing the landscape of how these medications are even tested. But maintenance is going to be absolutely huge. Patients are going to need something to help hold the line. And data like this is early, but it's really encouraging. And so we'll have to see how this holds up at the higher doses. If the side effects stay low, this could be a huge conversation shifter for the future of obesity medicine. You heard it here first. That is, once again, Wave Life Sciences and WVE-007. This is the James Bond of weight loss. I want to take a moment and thank our sponsors. Of course, you can always visit our sponsors by going to otplinks.com. That is the gateway to all of the resources that we talk about on this show. It's a gateway also to the sponsors of this show. And the headline sponsor of this show is Shed. So you can go to shed.com or tryshed.com and use code OTP25 to save 25%. Listen, the cool thing about Shed is that they're going to connect you with a provider. They also have a bunch of patient resources, coaching available. If you have the disease of obesity, you not only want access to a doctor who can help you navigate the world of the treatments that are out there, but you also need options because everybody has different insurance situations, different income situations, and Shed has sort of a solution for everyone. So I want to just let you know that Shed is the headline sponsor of this podcast. We really appreciate their partnership, and if you would be interested in checking them out, go to tryshed.com and then use code OTP25 at checkout. Thank you, Shed, for being such a valuable part of what we do here at On the Pen, bringing patients information that helps them have better conversations with their doctors. Now let's talk about Amylin, because again, like I teased at the outset, this is the podcast about the future of obesity medicine, and Amylin is a huge one, and we've been talking about it for a long time in the context of Cagrelintide, CagriSema, which is the next one to come from Novo Nordisk. Now, we talked about how earlier this week, basically, we've got signals from Novo Nordisk that they won't be submitting that to the FDA until the second half of 2026, which means it'll be 2027 before we get it. And later on in 2027, we happen to be expecting retatrutide to come to market too. So we'll get both of those in the same year, which is a little frustrating. And I really believe that that's because you'll see the launch of the Wegovy pill in the next couple of months. That should be approved by the end of December. You're going to see the launch of also 7.2 milligrams of Wegovy, which is 3 times the highest dose that there is now, which gets the weight loss efficacy up there very close to what tirzepatide is. Now, I think the launch of 7.2 and the delayed launch of CagriSema is more about not wanting to cannibalize that higher dose. They're just wringing everything out of the semaglutide as they can. But I also believe that it has something to do with the fact that they don't want to launch CagriSema in these dual-chambered pens. Of course, the Cagrelintide and semaglutide have to be held at different pHs. So there's separate chambers in these pens. The pens are very complicated, and I think they'd rather just release CagriSema in a similar pen to the Ozempic pen or the Wegovy pen. At the end of the day, I think that might play into that as well. So when we talk about the reasons, it's just a whole host of market dynamics, but I think they would also like to wring out whatever they can out of semaglutide. But we've talked less about Lilly in the Amylin game. It was about a year and change ago that they started talking about this new molecule called Eloralintide. Now, Eloralintide is Eli Lilly's answer to Cagrelintide. So Novo has Cagrelintide, the amylin agonist. Lilly has Eloralintide. And this has kind of felt like just kind of a side project by Lilly. We'll kind of see what happens. And then we started to get some early data on the phase 2 trials, and we went, whoa. So Eloralintide showed us some data that patients got up to 20% weight loss at 48 weeks. And at that 48 weeks, at the highest dose of, I believe it was 9 milligrams, the curve was still trending down. So there's still more weight loss to be had in the longer trials. And so Lilly is going to continue to push that. And now this is fascinating to me for really a couple of reasons. When Novo Nordisk tested Cagrelintide on its own, they had a trial that lasted 68 weeks. At the end of the 68 weeks, at the highest dose, Cagrelintide alone reached 12% body weight. And the numbers I just told you with Eloralintide was after 48 weeks, so 20 weeks shorter, and people lost a total of 20% of their body weight. So Eloralintide appears to be a far superior medication to Cagrelintide, and even up towards a weight loss efficacy similar to tirzepatide alone. But the cool thing is that both Cagrelintide and Eloralintide are likely to be standalone therapies, monotherapies for people who may need it, but more importantly, a combination therapy. We've already heard Lily talk about the potential of combining Eloralintide with either of tirzepatide, Zepbound, and Mounjaro, and or retatrutide, the triple agonist. So when you combine those forces, again, we talk about this a lot at On the Pen, the future of obesity medicine, we're very close to, and I mean just a couple of years away from there likely being a option on the market for 90% of people living with obesity in terms of getting their weight down. And that's why you see the future of these medications, like the James Bond of weight loss that we just talked about, focusing on the quality of the weight loss. Because, back 10, 15 years ago, it was like bariatric surgery was the only option to get people's weight down when they were looking at medical interventions. Then they thought, how can we get weight loss down with medications? So they turned to the incretin class of hormones, because they noticed that the incretin hormones were seeing a restoration in patients who received bariatric surgery. Now, within just a very short amount of time, we've seen the conversation shift to quantity to quality, and I think that is extremely positive. And this is all on the heels of the FDA announcing that they're likely going to do away with most phase 3 clinical trials. What would effectively happen is phase 2 trials would just broaden, get larger, and they would use that data for being pivotal data that they could submit to the FDA for approval. So we're talking about the timeline shifting for these medications, and I think it's just super, super fascinating and super exciting to be covering this at this time, at this juncture in history, because this is so positive. When we talk about the disease of obesity, it's never been closer to being eradicated, and that is such an exciting thing. So Eloralintide, super exciting, 20% weight loss after 48 weeks. Mechanistically, it binds to the Amylin 1 receptor with a 12 times greater potency than the calcitonin receptor. So it's targeting the Amylin receptor without targeting other things too. Without targeting things or binding to things that they don't intend it to bind to. So the molecule includes a C20 fatty diacid to support albumin binding, which extends the half-life for the administration. So it's even a longer half-life than Cagrelintide. And they're also seeing an improvement in some of these secondary markers like lipids and blood pressure and C-reactive protein, which is associated with inflammation. These findings are going to matter when it comes to submittal of this medication, and it'll be interesting to see how Lilly positions this in the marketplace as it's already just completely stacked with its obesity pipeline. So we'll see what their phase 3 timelines are on this. We don't have those yet, but I'm really excited to look at the combination trials with other medications like retatrutide or retatrutide. It's going to be very interesting to see what happens with all that. And of course, we will keep you posted here at On the Pen. Want to give a shout out to Shapa, though. If you're just looking at getting on a GLP-1, especially, you shouldn't start without looking at Shapa. Shapa is the numberless scale. It does wonders for me because it keeps me engaged with the scale. And it does that by being a numberless scale. So have you ever stepped on the scale and been 5 pounds up from the day before, but you did everything right the day before? And even on an intellectual level, I didn't gain 5 pounds, but it does a number on you mentally. That's my issue. And then I don't want to step on the scale the day after or the day after or the day after. And so I disengage with the scale, but then I'm also like low-key disengaging with my health because I'm not also stepping on that scale every morning to sort of set the tone for the day in terms of the intentional movement, the intentional eating. Shapa fixes all that by zooming out and giving me 10 days worth of data at a time instead of just a snapshot. Here's what you are today. It says, here's where you're tracking over 10 days, and it drops you into a color zone. Right now I'm sitting in the green. It means I'm maintaining. But if you move down into the teal or the blue, it means you're losing. And up into the gray zone means that you're gaining. I would highly recommend the Shapa scale to anyone who is starting a GLP-1 journey, or even if you're deep into it and you just want to have a healthy relationship with the scale. The Shapa scale helps me to do that. I think it might be able to help you too. home.myshapa.com/OTP. Going to tell you all about the Shapa scale, and then you can use code OTP30 to save 30% on your Shapa scale. So there's just so much to talk about right now in the world of the future medications. And we can't talk this week about the future of medications without also talking about Structure Therapeutics. Structure Therapeutics had another, I think at one point, 150% jump in their stock. And this was all on the heels of data about their own small molecule GLP-1. It's like an orforglipron basically dupe, right? It's going to contend right there with orforglipron, a small molecule daily oral GLP-1 called analigipron, or you could also read it alaniglipron, like Alani the drink. Maybe that's what they're trying to piggyback off of, alaniglipron. However you pronounce it, their stock doubled in a day. And listen, I get it. Oral GLP-1 has been the holy grail to Wall Street for some time, and people are very excited about this. I don't know. I'm not sold on this data. I'm definitely not sold on the hype that jumped their stock, but basically 11.3% weight loss was observed at 36 weeks with no plateau. That's pretty good with an oral, potentially best-in-class medication. They went way higher with the dosing on this one, over 100 milligrams, I think maybe 120 milligrams once daily, where orforglipron capped it out at 36 milligrams. This is not a peptide wrapped in an absorption technology. This is a small molecule GLP-1 non-peptide. And everyone knows the risk profile here because we've talked about danuglipron. That was Pfizer's attempt at this, which crashed and caused liver issues and safety signals. So Structure was able to ramp the dose up without showing liver signals. So, kudos to them. But I'm not sure what the hype is here. We also saw that Pfizer, I think, acquired another company with another small molecule candidate, smaller company, but it was like still a multiple billions of dollars acquisition. Everybody wants to get in the small molecule game. I think it has to do with the manufacturing of it. It's just an easier, cleaner manufacturing process than peptides. And of course, you get that oral bioavailability that you don't get with the peptide versions. You don't need an extra technology to wrap the peptide in to get it. So it matters for patients in terms of just another option, perhaps another maintenance option, something that might be better than orforglipron if you're getting really excited about orforglipron. But honestly, with the future of these medications, scalability matters, accessibility matters. If to people who can't get the injectable kinds or don't want them for whatever reason, this is exciting. But honestly, the game is in the future of these injectables, which seem to be the future of these. So really exciting. But I think that the hype, the increase in stock, it seems overblown to me. It all seems very overblown to me. We'll have to follow this one. Structure Therapeutics, they're probably primed for a takeover, a buyout now, but we'll have to see kind of how this one lands. The last story I want to get into is just, we got into this on the live the other day. It's a story that we've followed for 3 years now, and it's a fake Ozempic story. And we need to talk about this not because it's new, but because it's persistent. And I think it should be one of the largest stories in medicine right now. So essentially what we have is we have more fake Ozempic pens that have gotten into the supply chain via pharmacies. Pharmacies buying from bootleg distributors who have fake Ozempic pens that don't have the real medicine. So everything pretty much looks the same as a real pen, and it's not actually Ozempic inside it. So first of all, I need you to know if you have that medicine, I'm going to give you some ways that you can identify it. If you have it, don't take it, and call Novo Nordisk, call the FDA, call your pharmacy, call everybody. Call your kids, call your mother. Everybody's getting fake Ozempic out here. But let's take a look at this one together because I think that this is an important one for everyone to be aware of. It's also available at obesity.news on our Substack, where we dropped an article about this a couple days ago when it came out. So here's the picture here, and basically we can see this on this side of the screen here is the authentic Ozempic image. You can see where it puts the expiration and lot words, right? Compare that to the fake pen where it's over here to the left. That's the counterfeit version. So that's really the way that you can tell. And the PAR 1229 is the actual lot number that we have in question. So look for PAR 1229 and then look for where your EXP lot is written over here on my left, my right. I don't know. I get so turned around with the screens. You can see where I'm pointing though, right? Expiration lot is above it and justified to the left, where on the fake pens, the expiration lot is just to the left of where the lot number is instead of above it and to the left. And so that's the way that you can tell. Contact the FDA, contact Novo Nordisk, let them know if you do have these fake ones. And again, you can get this image by going to obesity.news and looking at the lead story there today. If you're listening after the day that this released, just scroll down a little bit or search for Ozempic. And you should be able to find that. So that's what's going on. But, this is where I feel like this should be one of the biggest stories in medicine, because how do we know that this isn't happening with other medications? And Ozempic being an injectable, a lot of money to be made, of course, but how do we know this isn't happening with cancer drugs? How do we know that this isn't happening with more expensive pill versions that are even easier to fake? Right? I'm very concerned about this, and I'm very concerned also that this isn't leading headlines everywhere. And I have been concerned about this for 3 years, because we ought to be able to trust that when we go to the pharmacy, it should be a sacred place that we put a lot of effort and energy into to protect the sanctity of it. People need to know what they're putting in their body, and they deserve to know. We pay a lot of tax dollars to have the FDA making sure that our medicines are safe. We have to have some sanctity here when we go to the pharmacy, and we have to know that what we're paying for is what we're getting. Furthermore, I think it's just worth noting that when we talk about the last couple of years and the assault on compounded versions of these medications and how they're not FDA approved and they're patently unsafe, you got to get them from your doctor. You got to get them from your pharmacy. Like, the pharmacy doesn't seem to be reliable either, right? I mean, it doesn't seem to be the be all end all like they've made it, right? So I just find that interesting, and I do wonder if that's part of the reason we don't see this in the headlines. Why don't we see these things in the headlines of the nightly news? Is it because they've got a little bit of, these pharmaceutical companies have a little bit of influence over our media, right? Because of all the advertising spend, right? And they don't want to erode that trust in the system. But we should be asking questions. Patients deserve to know, and we should demand that the FDA be looking into this further, and that our media actually covers this. So that's another reason why you follow On the Pen here. We've been covering this story for 3 years. It started over in the European Union. I warned you it was going to make its way over to these United States, and unfortunately it has. This time they don't know what's in the pens. They do by now, and they need to let us know now. But in the past, it's been insulin. And if you're injecting insulin unknowingly into your body, it's a very dangerous situation. So check those lot numbers. Check On the Pen at obesity.news to download that picture if you'd like. They've also got it on the FDA website. It's just harder to find, but you can find it at obesity.news. You can do that today. I really appreciate you. That's what we got this week. Wave showing us a brand new direction in obesity medicine. That's huge with a single dose. Lilly giving us the Amylin data, structure, with their small molecule oral. Just so much going on with the future of these medications. I'm very excited. Let me know if you're excited in the comments too. Let me know what you're most excited for of what we talked about today. Is it the Amylin? Is it the James Bond of obesity medicine coming down the pike? Or is it the orals? What do you think about the orals? Are you excited for them? I don't know what to think of them, but I do know what to think of this community. I'm so grateful for you. Thank you for giving me the ability to do this each and every week with you. So appreciate it. If you're listening on the podcast, leave us a 5-star rating and review when you're done. Really appreciate that. And we will catch you on the next one.
Happy holidays. Want to give your host a gift? Consider subscribing, rating, and reviewing the show this holiday season. It really helps the show grow. From all of us at Believe, have a Merry Christmas, everyone, and a happy holiday. If you like the show, please take a moment to rate, review, and subscribe. It really does help the show to grow. Thank you for listening.